All right, if everyone would take their seats. All right, we want to welcome everyone to our meeting of our Public Pension Oversight Board. And Madam Secretary, if you would, please call roll.
Senator Chambers Armstrong. Senator Elkins. Here. Senator Funky Fromeyer. Senator McDaniel. Senator Neal. Senator Nemus.
Present.
Senator Wilson.
Here.
Representative Bojanowski. Representative Camuel.
Here.
Representative Duval. Representative Fleming. Representative Johnson.
Here.
Representative Petrie. Representative Tipton.
Here.
Auditor Allison Ball.
Here by proxy.
John Hicks. Victor Maddox. Representative Hale.
Here.
Co-Chair Higdon.
Here.
Chair Thomas.
And present. We do have we do have a quorum and approved to do business. But before we do, please stand. We're going to do the pledge, and followed by remain standing, and I've asked Representative John.
Please join me. Father, we do thank you for this opportunity that you've given for us to come together and do your work. Lord, we ask that you guide our hearts and our minds, open our minds to ideas, and help us use the wisdom that you provide to us to make the decisions that are best for the citizens of Kentucky. Lord, we ask all of this in your name. Amen. Amen.
All right, and let's see. I need approval for the minutes. Motion by Representative Tipton and second by Representative Johnson. All right, anyone opposed to that? Good. All right, we are going to mix things up just a little bit. We are going to go with the Deferred Compensation Authority update. Chris, I know. Come take, and you've been here before, you know the routine. Just make sure the lights are really green and introduce yourself for the record, please. And your guests there.
Good afternoon, Mr. Chair. My name is Chris Biddle. I'm the Executive Director for the Kentucky Public Employees Deferred Compensation Authority, and this is Scarlett Murphy. She is the one that is responsible for our marketing and these slides. Just going to jump in today and give you a quick update. We've got some implementation from last year's legislation. I'm going to report on some of the previous year's projects because they are pretty interesting as far as results. So if we can go ahead and advance the slide. So as of yesterday, we are $4.787 billion, which is quite a lot since more than I came. When I came in 18 years ago, we were $1.2 billion. So we're 4x that number. Pretty interesting. The 88,000 participants is very interesting as well. That's closer to 90 than it is 88 now. And just can't wait till we break 100. When I took this plan over, we were 3 years in decline, and that's when we moved on auto enroll, which has been a complete game changer. Let's go ahead to the next slide. There's more of the plan assets. You can see as it continues to tick up. Pay attention to the 401k and 457 balances there on the 2025 at the bottom, the 46 and the 43. That'll become relevant when we get ready to talk about the self-directed brokerage account. Let me go ahead and advance the slide. These are the participants. You can see the active versus the passive, and we're somewhat unique in that we cater to retirees. A lot of plans do not. They allow them to stick around, but they don't cater to them. We cater to the retirees. This is a program for life. We have financial planning, and we can take you from as a new employee all the way through retiree issues and everything in between. This helps the retention of assets, just really helps us be able to use leverage on the pricing when we buy these mutual funds. So we're headed in the right direction there. There's the auto enrollment, 94% retention rate. I don't know how or why, but that stays static within a percentage or so. That's one of the highest I've come across in asking anybody and everybody that has auto enrolled to compare notes, and we're still top dog as far as I've been able to discover. That 21 number is also, at the end of this year, will be closer to 25,000 than the 21. So we get all these people in here at $30 a month. That changes our game. Our game is deferral increase, because if we don't have them raise their deferrals, I'm fond of saying I'll be running an acorn farm instead of harvesting mighty oaks on the back end. So we've got to pay some attention to the front end and the new employees. And so we've been doing a lot of marketing around the increases. And you can see we've had a lot of success. The main thing that has really helped has been the raises. So if you go ahead one slide. This was a targeted 4-year targeted marketing campaign that we basically partnered up with the personnel cabinet, because they have an email blast out to all of our eligibles. Basically anybody that can participate in the health insurance can participate in deferred comp. And so we use them to message out. And we timed this for before, during, and after the raise periods. And as you can see, just that July month versus the previous 6, those were the increases around that. So you look at the money, let's loose math, let's call it $8 million over 4 years. That's 12 emails that don't cost anything, not a penny, other than general infrastructure is already existing. And so we were able to pull in an extra $8 million over that 4-year period. So we think that's working pretty well. We're going to continue to, as you can see, we're all over that. But that's a key component going forward, and we like those numbers. All right. Self-directed brokerage accounts. It was passed last year. That 40,000 account balance. So when we discussed this previously with this board, we mentioned that we were going to emulate the federal plan. And I had conversations with them, and this is more based on our demographics. Their account balance for eligibility to participate in the brokerage account is higher because they have more dollars per head. We think that this is about where we're going to make eligibility, and then you would be eligible to move up to 25% of your total balance into that brokerage window to purchase what you would like to purchase. That is slated for tentative implementation July 1 of this coming year. Any questions? Okay. Financial planning program. This is where we provide free CFP service to every participant on demand. And we are probably mid 3,000, 3,400, 3,500 participants that have taken part in the certified financial planning program. What we've seen, I'd like that number to be larger. You have to put budget information and a lot of detailed financial information in the front end to participate in that. But what we do see is of those 3,500, approximately 87% of them are returning to utilize the service. So you're building a solid cornerstone, and as we continue to advance that, we hope to see that continue to grow. And then financial education tools. Our vendor Nationwide has done a lot of revamping in the last year, so we will be getting enhanced, they call it MERP, My Interactive Retirement Planner, and in essence a suite of financial calculators. Go ahead. And that's my presentation, unless there's any questions.
All right. Do we have questions there? Senator Funky Fromark?
Thank you. On the financial planning program with certified financial planners, is that also offered by Nationwide?
Do they offer? It's a service that's an includable in our package. But yes, they do.
in
Like to other state plans? Is that what yeah.
on the Kentucky Deferred Comp, who's offering the CFP service?
We do. It's a service that's rolled into our service bundle. They don't, well, they're not getting paid. There's no, it's not a for fee service. If that was, is that where you're asking me? Kind of.
I actually was curious what's included in that, and I think there was some marketing that came across my radar.
Yep, I can get you an application packet, and you can see exactly what the participant goes through. I've done it personally. It's a lot of budget is really where you start, and then it takes from the very simple Dave Ramsey concepts of emergency funds and all that. But you can goal plan for anything, including illness or various types of illness. Grandchildren, college funds, or just general retirement. Any goal. A new Corvette, if you wish.
Yeah, I did. I'm just more puzzling around. I did receive a call back from a person from Nationwide.
Yeah, that's our vendor. It would probably be Brooks, I would think. That's the man's name that is our CFP. He runs that department. But he is a Nationwider. He's our vendor.
Okay.
And that's includable in our service contracts with them.
Yeah. Okay. All right. Thank you.
Okay.
All right. I know Senator Higdon, co-chair.
Thank you, Mr. Chairman. Just a comment, but Chris, thank you for being here. And Kentucky Deferred Comp is certainly a success story. And to see that 94% of those automatically enrolled,
Yes, sir.
continue to stay there and participate is awesome.
Yes, sir. We'll soon capture the lot of the state workers. So, again, we would ask for unified payroll access so that we can give this service to teachers. It's the most affordable option there is. We're currently in a fee holiday for the rest of the year. We haven't collected a fee from participants all year long, and that's a remedy the IRS provides to us. When we collect too much fees, then we fee holiday and it falls back and we start again. So, in the current level, with the way the markets have been producing, about every other year we're going to have some kind of a fee holiday. Short end 3 months, average probably 6 months, and sometimes we get a year when it's been a really boom year for fees.
And it looks like from the reports I see, your returns are doing very well.
Markets are up. Yes, sir.
Well, that doesn't always mean that your returns will be good.
Well, that's true. That does not mean that. But we've chosen wisely. My board has chosen wisely. We've had good counsel from our vendor, Cowan. They are the best investment consultant I've had in 18 years. They've saved us, in the aggregate, probably 9 figures. And then obviously if you extrapolate that, it gets bigger and bigger. But just, right during COVID, we did a lineup refresh and sort of streamlined it. Let's say we got rid of duplicative offerings and things that only 2%, less than 2% of the people would utilize and things like that. And it saved us almost $6 million a year in participant fees. So, you got to hit all the low-hanging fruit first, and then there's the bigger, grow the program type things. But all of these have been very successful, and it's been because of the joint support.
Well, thank you for that, and be sure to get us a copy of the legislation you're referring to, and we'll run it up the flagpole.
Okay.
Thank you.
All right. Thanks, sir.
I heard you just say one more question, just talking about fees, and I'm just trying to understand a little bit.
Yep.
Can you explain that fee structure, and are there caps on it?
Fees. Yeah, there is a cap. So we charge a total of, first there's a $1 a month fee, so that's $12, and the rest is capped at $225. So the most you could spend in any year without picking up a managed account, which is that's the only for-fee service we have, would be $237 a year. And we don't need to collect any more than that, because with collecting that amount puts us in surplus to where we're in an annual or a biannual fee holiday, at least over the last 6-8 years, something like that.
Awesome. Thank you.
Yes, sir.
Any other members have any questions?
Before you accrue that $237, you'd probably have to have about a small 6-figure account, $125,000 to $140,000, depending on what your investments are, because they have different fees.
At that point, I think they could afford the $225.
Right.
Okay. Great.
We like to think we're a bargain, and I always tell people,
$1 a month.
I always tell them I'll buy them a steak dinner if they can find a cheaper option, and so I haven't bought any steaks.
Great.
Yes, sir.
Thank you for all that good news. Any other members? Nope. Thank you, Mr. Biddle. We
Yes, sir.
appreciate y'all being here.
Thank you.
All right, this time, let's get Bo back up here and with the TRS system. I feel like this is a monthly occurrence for you to be here. And I know you know the routine.
Yes, I hope. I better. Here we go. Okay, there we go. Good afternoon, everyone. Good afternoon, everyone. Bo Barnes, Deputy Executive Secretary and General Counsel for the Teachers Retirement System. Today I'm making a presentation on retired teachers' health insurance. Before I get into that, I might address one issue. It was a question that came up at the last meeting, and I said that I would address it at this meeting, and that concerned a question from one of the members about a couple of our slides that show the various sources of contributions that come in to the Retirement Annuity Trust, which pays the pension out. And in particular, there was a column in a couple of slides that showed contributions that were made they were coming from employers that were not the state, okay? And I explained then that those contributions largely represented federally funded positions in the school districts for which the federal government pays for those positions, the salary, and they pay the normal employer retirement contribution match as well. And the specific question was to the fact that we were seeing, and we showed a historical pattern going back to 2019 and then projected forward 3 years into the future. And we saw over that period of time that there were differences in the years. You know, they fluctuated. For example, in 2019, there were $72 million received in contributions from federally funded positions. And that grew kind of slowly over the years until it hit $109 million in 2022. Then it declined again to $102 million in 2023, and then kept on sort of slowly declining until this year. We were getting $85 million in contributions from federally funded positions paid by the federal government. And then we showed a projection of it declining to $80 million over the next 3 years, contributions from federal government. So the question was, basically, to paraphrase, what was the financial impact of those declining federal dollars? What does that mean? And if those contributions are not coming in from the federal government, then those contributions would need to come in through the SEEK formula. So we're talking about that standard fixed statutory rate that employers pay toward the Retirement Annuity Trust, and we would need to collect those from there. As if they're not, and again, we don't know what future federal budgets are going to hold. We just use $80 million projected in the future for the next 3 years. That could hold at $85 million. It could go down more than $80 million. It could go up more than $85 million. We just don't know at this point, but we just use it as a projection. But I think fundamentally we were asked is the mechanics of what happens as a result of that decline. And I just wanted to address that, to get back with that before we start in today's topic, which is retired teachers' health insurance. So the first slide I'm going to start with, and this is an important thing, and I know this body knows this, but I think it's worth repeating, everyone here is aware that there's a statutory and viable contract guaranteeing benefits provided by TRS. And as we've presented to this body before, there's a qualification for some of those benefits, and health insurance is one of those benefits that's somewhat qualified and what's guaranteed, because under the inviolable contract, only access to group coverage is guaranteed. But how much that retiree has to pay for their health insurance coverage and the levels of coverage provided by TRS, those are subject to change dependent upon the available funding to pay for those benefits. Next slide. There are two plans, if you will, that are administered or that are provided by TRS for our retirees. The first one is the Kentucky Employees Health Plan, or KEHP. And most of you all will recognize that as the one that is administered by the Personnel Cabinet's Department of Employee Insurance. TRS does not administer this particular plan, but that is the plan that our retirees who are under age 65 or who are otherwise not Medicare eligible, that's the one they participate in. And it's the same insurance that active teachers and active state employees receive as well. So when our active teachers retire under the age of 65, it's very seamless for them as far as health insurance goes. They just go from active KEHP to retired KEHP. And in that plan, there are a number of options they can choose. So when we talk about cost or cost trends for KEHP, we give an average, but there are also costs and cost trends for each of the individual options that are provided by KEHP. The Medicare Eligible Health Plan, or MEHP, is a plan administered by TRS. And this plan is provided for our retirees who are age 65 and over or who are otherwise Medicare eligible. And unlike KEHP, this is only for TRS retirees. This doesn't apply to anyone else. And then, unlike KEHP, we have just one plan we offer as a Medicare Advantage type plan. Okay. Recently, TRS issued 2 requests for proposals, or RFPs, for providers for their health insurance plan. And these services were to begin in January 2026. We're already getting these services, but we requested the RFPs, just to evaluate whether or not there are any other providers out there that might provide better cost or better benefits than the current cost and benefits we were getting. So we did that. And there were 2 RFPs that were issued. One was for the prescription drug side of the TRS MEHP, and the other RFP was for a provider for the medical side. And the medical side is basically everything that's provided in the health insurance plan, excluding prescription drugs. So we did those as a very deliberative, lengthy process, and as a result of that process, we decided that TRS would stick with Express Scripts to take care of the prescription drug side of the MEHP. So no change for members there. But on the medical side, on the Medicare Advantage side, the plan will change January 1st, 2026. We'll be moving from United Healthcare to Humana. And many of our retirees will be familiar with Humana and have had a good experience with them because Humana was our provider from 2007 to 2014. So, they worked well then. It's just we did an RFP back then, and we felt like we were getting a better deal with United Healthcare at that time. TRS's goal with this process, just to let you know, because our members can get kind of anxious about when health insurance changes, and we get questions, and I've made appearances to talk about the change in health plans and what the changes we're making. The goal with this always is to make things as seamless as possible for our retirees, so there's no real disruption in this very important benefit that they depend on. So these RFPs were actually designed, to maintain the existing plan design, and very importantly, without any material changes, and very importantly, maintaining the same out-of-pocket cost, very importantly, same access to physicians, pharmacies, and hospitals, and also, obviously, very importantly, the benefits do not materially change. We did get a little benefit with this new provider beginning 26 with hearing aid coverage, $500 per ear. Okay, we were also asked today to address the cost of the plans, these health plans for 2026. And this process is that the TRS Board of Trustees each year, it's always been a September board meeting, in my memory, will approve the maximum amount that TRS will contribute to the cost of both the KEHP and the MEHP. The TRS Board of Trustees is given statutory authority to do that under KRS 161-675, subsection 4. So what's that going to look like for 2026? The board, just as a recent board meeting, approved a supplement towards the payment of health insurance in the KEHP at a maximum of $1,044.96. The actual amount paid will depend on years of service, of course, and that sort of things. It's tiered. You have to have 27 years of service if you're in TRS 2, 3, or 4 to get that full $144.96. If that's the plan you're selecting, that's the more expensive plan, or that plan. Not more expensive, but that plan, or any plan. That's the maximum amount we'll contribute. And that's an increase from the current year, which is at $930.76. So that represents an 18% increase from 2025 to 2026, about $159 a month for the state. And I'll talk about the state's role in paying for health insurance here a few slides later, but that represents about $15 to $16 million more a year that will be needed in the budget for health insurance with this increase in KEHP cost. And that's flexible. That certainly depends on the number of enrollees. The number of people our retirees in KHP could change between now and next year. So there's always some state of flux, if you will, in these numbers. In regard to the TRS Medicare eligible health plan, the MEHP, it will be $200 a month beginning in 2026. That's down from the current year at $210 a month. And the reason it's going down is because TRS negotiated that lower cost with his RFP and with his new provider, Humana. We've also been asked about the actuarial impact of these premium changes. So with the Kentucky Employees Health Plan, cost is going up. The cost of the benefit is going up. That's a negative actuarial impact. I'm talking about overall actuarial impact here. With the MEHP, of course, we're seeing a positive experience because the cost is going down from $210 to $200. So I asked our actuary about this, and using the 2024 actuarial valuation, and we're not going to change that. This will be reflected in the next year's valuation, but just using that to show the impact of what those premium increases mean, we would see the funded ratio for the 2024 valuation with these premiums would have decreased slightly for the health insurance trust from 80.4% to 80.1%. And we would see a slight increase in the unfunded liability for the health insurance trust from $4.036 billion to $4.051 billion. We've also been asked about our assumptions about medical inflation trends, what we assumed for the last 5 years and what actually happened. And we don't quite have the 2025 numbers yet, but based on the 4 years before that, our actuaries will assumed inflation rates for medical insurance for each year of those 4 years, and those fluctuated between 6.5% and 7% for the KEHP, for the Kentucky Employees Health Plan. So 6.5% and 7% was the assumption. Actual average inflation rate for those 4 years was 6.18%, or slightly below the lowest projection the actuary had. For the Medicare eligible health plan, the MEHP, for each of those various years, they had projected inflation from 5.125% to 6.75%. The average actual inflation rate for those 4 years was 4.22%. And again, lower than what the actuary had projected. This is a slide, is a historical demonstration of the rates, the premiums for the MEHP since 2021, for over a 25-year period. You'll see at the far left-hand corner, that represents 2001. The premium for the MEHP was $210. If you go to the bar second to the right, you will see that in the current year, it's still $210. And you'll see, of course, what I discussed earlier, that we've negotiated a lower rate for next year at $200. You see there's some fluctuation in there, but generally it's held very constant over the years, and that's not an accident. We have an in-house insurance staff who are extremely professional, extremely knowledgeable, and well-trained, and they do a whole lot to keep costs down. We have two of the bigger ones mentioned here, but they are no means by far the only constant reevaluations and changes that we are making and our staff are making and recommending to keep costs down. But two of the big ones being and taking advantage of the federal Medicare Advantage plan very, very early on, very proactively on that to garner those federal subsidies to help keep costs down. And then also instituting a self-funded employer group waiver plan for the prescription drug side. It's also comes with subsidies that help us keep costs down. And again, those are two of the big ones, but by no means the only that have helped us keep these rates constant. I want to talk a little bit about this. This is very important. Shared responsibility. That was landmark legislation from 2010 that we've talked about here many times before. Basically, just one more time, I know sometimes we have people, new guests here. Before 2010, retiree health insurance was basically a pay-as-you-go benefit, dollars in, dollars out. And the Commonwealth of Kentucky was paying almost all the cost of retired teachers' health insurance. Again, that statutory viable contract only guarantees access to group coverage, but they could be required to pay a lot or all of it, the cost of it, depending on funding. So the Commonwealth voluntarily paying for all of it really wasn't working. We all knew that. Members of the General Assembly knew that. We knew that something had to be done. The TRS board instructed staff to start meeting with stakeholder groups a year and a half before the 2010 session to come up with a solution for sustainably funding retired teachers' health care. And there were like 30 different options that were looked at, and everybody agreed on the same one. And the one they agreed on, we had active teachers phasing in to paying an additional 3% out of their paycheck into the health insurance trust. They were already paying 3/4 of 1%. This added an additional 3% over a period of years. The school districts matched that phase in, paying for the very first time anything into the TRS health insurance trust. Retired teachers under the age 65 agreed to phase into paying towards the cost of their health care an amount equal to the federal Medicare Part B premium, which our teachers 65 and over pay to the federal government. And the Commonwealth of Kentucky, which had been voluntarily and very appreciatively paying for all the cost of health insurance before 2010, stepped back to just paying for the cost of new retired teachers under the age of 65 in the KEHP. And by new, I mean those teachers who retired on or after July 1st, 2010. Commonwealth also provided some stabilization funding in those early years in significant amounts as those teachers and school districts and retirees started phasing into paying more of the cost of coverage. Now, we are now in the second decade of this landmark legislation, and this is what's happened. I know this body has seen this before, but it's amazing. It's worked better than we could have thought. That you see there at the bottom left, 2008 we were 2.9% funded. 2009 3.5% funded. That reflects that we were a pay-as-you-go plan. Then we start transitioning to a pre-funded plan. And you can see how sharply and strongly the health insurance trust grew. To where, as of the last year's valuation, it was at 80.4%. And that's just tremendous. We've been asked this, we are currently projected to be 100% funded in the next couple of years. So good news there. And the next couple of years is 2027, end of 2027. Now, there's a caveat with that, and I always mention that. The cost of health insurance is largely funded with those federal subsidies that we are getting and have been getting since we implemented the Medicare Advantage program. It's also funded largely with formulary drug rebates that we get from the drug companies. So keeping these costs down depends on both of those items remaining fairly consistent as they have been over this time period we're looking at on the screen, on the slide. And also medical inflation, very importantly. If it stays sort of constant with where it has been over this time period, then we will be 100% funded in that short of a period of time. This just shows how the contributions, the funding for the health insurance changed. We're going from 2006 on the left-hand side to 2026 on the right-hand side. You see that top line was the state paying for almost all the costs, and that continuing to grow sharply. That's why we all knew this was unsustainable. And then we see share responsibility 2010. We see it go up a little bit with that transition funding that the Commonwealth provided while those contributions from teachers and school districts phased in. And then we see it dramatically declining after that until we get to around 2015-16 where it starts to level off. Conversely, we see contributions by teachers and school districts increasing over that same period of time and now paying, for most of the cost of this benefit. So that was a tremendous legislation that we're very appreciative of. And we know our retirees are too because it saved their health insurance. So the previous slide showed how constant costs have been over that 25-year time period. Here's another way that, and there are many, this is another way, though, that TRS keeps costs low in addition to the two mentioned earlier. TRS partnered with University of Kentucky and the University of Louisville to start this new coalition called the Know Your RX Coalition. And initially, largely, we were doing that to achieve greater ability to negotiate lower prescription drug prices. When you have more people buying, more buying power, and they want your dollars because there's a lot of dollars there, the drug companies are willing to give you better deals. So we did it mostly for that initially, but we also had some pharmacists on board there too. Okay, they're in Lexington. And these pharmacists are accessible to our members for them to just call them up anytime. I've done it before. And you can call them and ask them questions, and they're there to help you. And then we now have 13 pharmacists in Lexington, and they take calls from our members all the time about a lot of things. I'm going to mention one of the big ones here, next slide. But now there's 13 there who consult with our members. And initially, they were largely engaged in medication therapy management, which is looking at the prescription drugs that members were taking, making sure they're right for them, but making sure also, more importantly, in containing costs, that if there was a generic drug that worked just as well for them, that they would suggest that they look into that, and they would even talk to that member's doctor and talk to them about the possibility of using a generic at a much cheaper rate than a brand name drug. And that work was very effective. That's worked a lot. A lot of people were like, hey, I'm fine with generic. A lot of people moved to the cheaper drug, again, helping to lower costs for not just TRS, but for them too. Here's another part, an outgrowth of that Know Your RX coalition, which we had to have those pharmacists in place for this to work. And again, TRS being very proactive on the health insurance front, to achieve not just cost savings here, but also better health outcomes for our members, very importantly, even more importantly. So TRS instituted what's a personalized medicine program. And the science behind this personalized medicine program was not new at the time we instituted this several years ago, but the widespread application of this program to a large pool of people who were users of prescription drugs or provided for by an institution like TRS, that was fairly cutting edge. That was pretty new. In fact, our director of retiree healthcare was invited to Harvard, to the National Institutes of Health, and other places, to Johns Hopkins, I believe, to discuss our approach to this program and how it was working for us, because they wanted to learn more about it and see if it would work for them. And it has been a great success. What it is, basically, let me explain. So before personalized medicine, doctors with prescription drugs are pretty much shooting in the dark. They have somebody with a known condition. They know that there are drugs that are used to treat that condition. But depending on genetics, a drug might not work for someone. You can give them all of that drug you want, no effect. Or depending on genetics, they're going to metabolize drugs differently. So you might give them a low dose of a drug that is never going to work for them because they're a high metabolizer, and that medicine goes in and it goes out very quickly to no effect. Or conversely, they might be a very slow metabolizer of that drug. And that is very serious, because at that point, when they're a slow metabolizer and they're getting maybe an average, a medium, or a high dose of this medication, it's going to build up in their system and become toxic. A lot of people go to the emergency room. There are even a lot of deaths from people who suffer from, or experience a toxicity in their system from being really slow metabolizers of drugs. But with this program, and it's voluntary with our members, we started with our MEHP program, which is the one that TRS administers, and we pay for the cost of it, voluntary with them. We gave them the option of taking a DNA test. A package is sent to their home, they spit in a tube, they send it to the lab analyzes it, and then they can tell with certainty, not a guess, not shooting in the dark, they can tell with certainty which drugs work for our member and which don't. They can also tell with certainty, what type of metabolizer they are and what dosage is appropriate for that member. So we avoid having trips to the emergency room. We avoid the tragedy of a death because someone's taking too high of a dosage of a drug that's building up in their blood system and has become toxic. And then this also saves the retirement system money. So this has just been a huge, great experience for TRS and for our members. It's a program that's gaining steam. I know there was some biosimilar medication here that this body passed out. Seem to be kind of following maybe that a little bit as well, interest in that. And then this is my last slide. And this just shows you on the left-hand side, these are the 20 most common drugs used by our members. You'll recognize a lot of those names there. And these are drugs used by our members, the most common ones that actually have a genetic implication, so that there's a gene we can test for to see whether or not the medication's on the left, and others too. But these are the most common ones, most used. The ones on the left, whether or not that drug will work for that person or not, and the right, dosage too, of course. And on the right, you just see the diseases that those drugs are used for to treat. And there are all the common, ailments that I remember that people have in general. And so it's a really widespread application of this testing that this personalized medicine that we have. And it applies to so many people with so many different conditions and drugs that it's really helpful for them. And again, it saves us, the TRS, the system, money too. So that concludes, I believe, everything I was asked to address regarding retired teachers' health insurance. I know that was a lot, and certainly if there's any questions, I'm more than happy to take those now on this or any other subject.
We appreciate your presentation, and I think I did hear that the plan's looking at being fully funded by around 2027, into 27, but that's a projection. I mean, that fluctuates.
Yes, they're expecting the valuation for the year ending June 30th, 2027 is projected to be 100%. Wow. Now, it may not be exactly, I would be surprised if it were exactly 100%, but right around there. And again, it's as long as those three factors I mentioned, subsidies, rebates, and medical inflation stay, fairly consistent, yes.
Great. All right, we do have a couple questions. Senator Flunky Fromeyer.
Thank you, Mr. Chairman. So the lower the use, fewer drugs that a person is consuming, then probably the lower cost of their plan.
Certainly.
And are there plans that would offer a high deductible health plan with a health savings account, so that a person that perhaps isn't using medications but they're trying to use a health tracker for their sleep or their nutrition or their daily activity and not use meds?
Yeah,
how do we manage these costs to even be lower, I guess?
Well, for the KEHP, there are optional plans there, including I believe there's still going to be a high deductible plan offered for 2026. Where if someone feels like I'm really healthy, I don't use my health insurance. Very rarely, I feel safe. Going with a high deductible, and then assuming that nothing is bad, it's going to happen to me, and I won't have to pay these huge out-of-pocket expenses.
So they do have a high deductible health plan with a health savings account
in the Kentucky Employees Health Plan. Now, for the TRS Medicare eligible health plan, that's a Medicare Advantage plan. Okay, so Medicare agrees to pay for certain things, about 96% of certain costs. Medicare will pay for. TRS picks up most of that gap, if you will. There's a $1,200 maximum out of pocket that our retirees could face if they're in the Medicare eligible health plan. And the savings we achieve through personalized medicine, for example, and the other things we do, that results in lower cost to us to provide for that Medicare eligible health plan for our member. And again, as I showed earlier, that cost for 2026 is going down to $200 from $210 currently. So that means savings for TRS because there's less money coming out of the retirement, the health insurance trust.
And are you finding a direct correlation with the quality of body mass index, that could be the one measurement compared to cost outlays? As their health is improving, the costs are also decreasing?
Yeah, KEHP would have the details on that side for the high deductible plan. For the MEHP, we did do a dive, and we have that now, but I don't have it today. But we did look at cost savings with the personalized medicine, for example. And we did see nice cost savings on that. I mean, very, very material, substantial cost savings as our members are getting the right medication and not wasting time and money on medication that's never going to work, or dosages that are never going to work, or that are going to result in them having increased insurance costs because they have to go to the emergency room now, which happens not infrequently. It happens a lot. So there's cost savings with that. And then also just we know also we have data on how many members found out they were taking the wrong medication and switched. I don't have that today either, but for members' health outcomes, certainly when you're taking the wrong medication and you're switching now to a medication that's efficacious for you, that's a positive health outcome. So, and then anecdotally, I don't know how many times I've been talking to a retired teacher group, and they're like, "Thank God I took that test. I've been taking whatever for 5 years, and I wondered why I wasn't getting better. And I finally took this test. And I was like, oh, this drug is ineffective. But this drug is the one that I need to take. And there are a lot of drugs out there, it might help like 30% of the population, but not the rest. And you have a lot of people taking drugs that simply aren't going to work for them."
All right, Representative Tipton.
Thank you, Mr. Chairman. Bo, appreciate you being with us today, and always appreciate you detailed information. My first question, if the chair will allow me to have more than one question, my first question is dealing with the 2026 premiums that the board approved for the under 65 and the KEH plan at $1,044.96. You may not have this document in front of you because it's in the KPPA presentation, but it's got premiums for their KEHP plans, and they have an example in here for a Living Well PPO single coverage for 2026 is $1105.54. So if my math is right, that retiree, if they chose that plan, would be paying like $60.58 out of pocket for that. Am I reading that situation correctly?
Yeah, so our board approved the maximum amount they would pay based upon the Living Well.
That's the max. That's the lowest amount they could pay, and they could pay more based on the years of service.
Yes, and ours is based on the Living Well consumer-driven health plan.
Okay.
Not the Living Well PPO, I think you said for
KPPA. That's just the one I had.
So it's a different rate that we base ours on. And then our member will pay, of course, that Medicare Part B premium subsidy amount, and then they'll pay whatever the cost of the plan is. I think that's around $54 a month right now.
Something like it. Now, if I could kind of add to that, in this particular plan, the cost for a couple is $2,238, so approximately double. And then if a member under 65 member chose to add their spouse to the plan, they would incur that cost as well.
Yes, I think people seeing the real increase in cost, and we looked at that. We had a lot fewer choosing dependent coverage in the KEHP, and it may be because of cost. We didn't have that many, but yes, that's where people are seeing costs increased. If they are single coverage, they're not seeing those big increases.
Sure. Now, am I correct that a few years ago, the amount approved by the board was actually covering spousal coverage at one point in time, or part of it?
So many decades ago,
Yeah.
spousal coverage was free. That ended decades ago.
Decades ago, okay.
And more recently, I think you're probably talking about, there is a non-single subsidy built into the Kentucky Employees Health Plan that helps people who have Parent Plus, couple, and family coverage pay for the cost of that plan. It's an inherent subsidy that active state employees and active teachers have if they're in the KEHP. The retirement systems used to also provide that subsidy. I don't think KPPA has for years, is my memory from hearing them testify before. And our board got rid of that as well, that dependent subsidy.
Wow.
It got brought back briefly with legislation for just a couple of years, and then to be phased out. But I think that was just to give some people who had gotten used
Now,
to it time to kind of wean off.
To emphasize your point, that was a decision made by the TRS board. I know that there was some conversations time that the General Assembly took that benefit away, but that decision's decided by the TRS board, correct?
Well, it was a little more than that, because our statute our health insurance statute is very specific about what we can provide, and TRS can provide no more than the single coverage amount. It cannot provide for that subsidy. So it'd been providing for it in the past, I believe, through budgetary language. Then it went away, and then it came back with, I think, it might have been budgetary language, or it could have been in a special bill that just said, we're going to bring this back for like 3 years and phase it out over a 3-year period.
And phase it out. I appreciate it. If I could go to another question, Mr. Chair. You mentioned the normal, that we're looking at 100% funding at the end of 2027. With the 18% increase in premium, if we see those kinds of increases again, do you have concerns that may limit our ability to get, if medical costs just skyrocket, is that going to hamper our ability to get to that 100% funding level?
Yeah, it is one of the 3 factors that, if those change dramatically, that is definitely going to change the trajectory we're on to be 100% funded. And inflation, including premium inflation in the KEHP, would certainly be one of those factors.
Okay, one final quick question, Mr. Chair.
Go ahead.
If my math's right, we're contributing 7.5% of payroll, everybody combined, plus the one-time budget appropriation into the TRS healthcare. When we get to 100% funded, and I think I've asked this question before, but if you could refresh my memory, going forward after we get to 100% funding, what will be the normal cost that would take to keep the fund going?
Obviously much less than what we're getting right now. It's going to go down dramatically. I'm confusing that with another number in my head right now.
I'm wanting to think 3 or 4%.
That is the number I have in my head. I can confirm that for you, though. I'd like to get that as precise as possible, and
But
I'll talk to our actuary.
I just
and
want to
confirm.
point that out to the members that even when we get to 100% funding, there's still going to have to be contribution from somewhere
Yes.
to
Oh, yes.
keep it funded at 100%.
Absolutely. The normal cost of the plan will still need to be funded, and that's going to be contributions coming in that, with investment income we earn on those contributions, will be enough to pay for the benefit when the teacher retires.
Okay, thank you.
All right. And Co-Chair Higdon.
Thank you, Bo, and always good to hear mention normal costs. I've always said there's nothing normal about normal costs. But back on the slide of talks about shared responsibility, where you have the graph shows the how the cost has been shared.
Yes, sir.
So one looks like an EKG.
Yes.
So does that include, is the $800 million that we bonded and repaid teachers' retirement from money we borrowed from them previous to 2010? Is that included in that?
That would not be reflected in this slide. That payment back in 2010 didn't go to the health insurance trust, but actually went, and this is just the health insurance trust here. So that would have actually gone into the retirement annuity trust to repay it back, if you will, not to use the best term of art, but anyway, to repay it for contributions that for just a few years were being reallocated from pension to health insurance. to keep that fund going. But then with shared responsibility, one of the great things about that too, and very appreciative of the General Assembly for doing this, was that they repaid all of that in full and made the pension, that retirement annuity trust, which pays the pension, completely whole from that. So that was just tremendous legislation. I again overstate its significance, not just for TRS retired teachers, but for the Commonwealth and taxpayers as well.
I always like to hear you say that we repaid the money that we borrowed.
Yes, sir.
Okay, that's always good. That's probably one of the misnomers that's out there. It's always hard to explain, but we don't hear as much now as we used to. But thank you for explaining that. Thank you, Bo.
Yes, sir.
All right, are there any other questions? Any members? Bo, thank you so much. We appreciate you being here and appreciate that presentation.
Thank you, Mr. Chair.
We got one more presenter. Ryan, I was looking all around. I couldn't see you behind that pole there, but I figured you were here. Come on up. Once again, you know the routine. That button, make it green, and introduce yourselves for the record.
Ryan Barrow, Executive Director, KPPA.
Erin Surratt, Executive Director of Benefits at KPPA.
All right, and the floor is y'all's.
Yes, just two housekeeping items similar to Bo. We had a question. Representative Petrie asked about the supplemental funding. There isn't really an accounting standard for that calculation, so we worked on it. We sent in a draft late last week, so we should have that calculation to respond to that question in the next week or so. And then I'd be remiss if I didn't, over my right shoulder, Rebecca Atkins, after 31 years of service, is going to retire at the end of the month. Just a few days left for her service to our members for a long, outstanding career. So I did want to mention her, and we didn't make her come to the table on the last week. So,
members, let's break and give her a round of applause then.
Thank you very much for that. I'm going to cover the first slide and then turn it over to the expert. Similar to what Bo said, we really have two buckets, the non-Medicare and the Medicare eligible. So just kind of the highlights, and Aaron will give some additional details. It's provided through the KEEP plan, as Bo articulated very well. The C and the K board select the contribution and the monthly contribution rate. And the Keep Living Well PPO plan has been selected since 2014. Moving over to the Medicare eligible, that is provided by Humana. It's a contract that we have for the Medicare Advantage, which Bo I won't repeat what he said. Like most large health plans, it's self-insured. Similar to the non-Medicare, the C and the K select the contribution and the rate. And the Medicare Advantage premium plan has been selected for 2026.
Okay, first, we didn't really get into the benefit structure for our members, but I wanted to give just a high-level overview of how that works for our retirees. For members who have a participation date prior to July 1 of 2003, their benefit, their premium, the amount that we pay towards their premium is based on the number of a percentage based on the years of service that they retire with. And then our hazardous members can also have eligible spouse and dependent coverage as well. For our members who have, and those benefits are covered under the Inviolable Contract. For our retirees who have a part date on or after July 1st, 2003, those are not covered under the Inviolable Contract, and that benefit amount is based on a dollar amount based on the number of years that the member retires with. And then there's some variations with that as well in that group of retirees. So first, just looking at the KEEP premiums, like Ryan mentioned, the Living Well PPO is the contribution plan that's been selected since 2014 on the KEEP plans. And we showed here the single rate. So for a member, like I was talking about, that had 20 years of service credit, if their part date was before July 1st of 2003, then that single coverage, the $1,105, would be covered in full. I showed the other plans on here as well, just to show that for a retiree with part date before July 1 of 2003, if they have a family to cover and a spouse, we would pay that, the trust would pay the full $2,453 for that plan. As you can see in the second line, we've done a 5-year look back to look at the percentage of increase over the last 5 years. You can see that last year, between 24 and 25, the rates remained the same, but this year there's been a pretty significant increase at 16.5% on that premium amount. And when we had our retiree health plan meeting, we had nearly 24,000 covered lives on the KEEP plans. And then just looking at our premiums for our Medicare Advantage plans, you can see quite a big difference from 2022 into 2023. For that year, in 2022, we went out to RFP. And again, Humana was selected as the vendor to cover the MA plans. In addition to being able to negotiate a really good premium price, there were some other things that were going on during that time that allowed Humana to offer a premium at that rate. There were much lower medical and pharmacy trends coming out of COVID during that period. Humana also issued gain share payments of nearly $70 million in the years leading up to 2023. That gain share still exists in our contract. However, as a result of market factors, Humana priced the 2023 rate so that the future gain share payments became much less likely, allowing us to benefit upfront from the more aggressive pricing. So, and at the time, claims and revenue were expected to continue their historical path, but that has changed with CM revenue not keeping pace with rising claims and utilization. So you can see in 2023, the really good rate, and then we had a 5% increase for the first 3 years cap, which allowed another good rate in 2024. And then due to some factors we'll talk about in the following slides, particularly the Inflation Reduction Act, we saw a pretty significant increase in 2025, and then we're still experiencing some of that increase into 2026. So we added this slide just to show kind of a breakdown of how the premium is derived. The total required revenue in that first line is per member per month, and that's the sum of the next 3 lines, the projected claims, the retention amount, and then the Humana business decision and retention reduction that they offered to help lower the premium amount. And then you can see Bo talked about the medical reimbursement from CMS and the pharmacy reimbursement from CMS, which results in a premium of $199.94. So $200 is the premium amount for 2026. Next. So, like I said, we've seen some significant increase in the premiums as a result of the Inflation Reduction Act that took effect in 2025. If you look at the lower graph, we've shown this before, in that IRA lowered the out-of-pocket for the Part D, which is the prescription drugs, in 2025. You can see in 2024, the out-of-pocket threshold was $8,000, and that was lowered to $2,000 in 2025. It will go up to $2,100 in 2026, but just increased a little. So some of the other things that have impacted the premium increases, of course, like I said, the implementation of Part D redesign, it mandated benefit enhancements, which shifted cost to the plans. So it was a really good benefit for the members, but those costs had to shift somewhere, and that it shifted to the plans. Plans are now responsible for a larger share of the catastrophic drug cost, and drug manufacturers must provide discounts in the catastrophic phase, and there's less CMS reinsurance to offset higher specialty costs on drugs. There's been higher utilization, which is also driving cost. I would say that from what I've heard, that's not just in the Medicare population, that's across the board in the Medicare and the non-Medicare groups. Prescription drug costs continue to rise. There's higher cost therapies that drive the prescription trend over the next several years. As retirees reach their maximum out-of-pocket, utilization could increase as retirees have no additional financial liability. Next. And I think that this graph is a good representation to show how that changes with the IRA has really impacted our population. As you can see, in 2024, we had 5,321 members who hit that catastrophic phase by the end of the plan year, which was December 31st. In 2025, as of June 30th, 2025, we had 9,732 members who had already hit the catastrophic phase with the new IRA design. We had a total of 8.66% in 2024 for the entire plan year. And already, like I said, at June 30th, 2025, 15.78% of our population had hit that threshold. In 2024, the average member cost share of the catastrophic threshold was $867. In 2025, that average has been $471. So again, those differences, the good for the members, but the plans, it translates to increased cost to the plans. And the next slide, and I'm sorry, these bars